Thank you so much. Appreciate the introduction, Susan. Before I start, I just want to say thank you to Brian Litch, Perfusion.com, and the organizing committee. This is my first time here in Sanibel and at this meeting. It's beautiful. So far, thoroughly enjoyed the meeting, so thank you for the invitation. I want to tell you a little bit about our hospital, but I have no disclosure, no financial disclosure to make here today, but I do want to let you guys know I am going to talk about commercial products that are not FDA approved just because it's related to the case report that I'm going to present. So a little bit about our institution. We're part of University of Texas Medical Center, UT Medical School, and our clinical affiliate is Memorial Hermann. It's composed of 14 hospitals, and we have 3 heart and vascular institutes. The main one, the flagship, is in downtown Houston. It is the world's largest complex. It's opened in 1945, and our hospital is actually the oldest, composed of 21 hospitals, 14 support organizations, and 10 academic institutions. Again, if you look at aerial photography, you can see that it almost looks like Houston has 2 downtowns. Well, one of them is the medical center, so it's pretty impressive. The case report I'm going to present today, it's pending publication in JECT. It's been accepted, and it should be out in the next issue. The two authors, primary and secondary authors, are our critical care pulmonologist and our director of lung transplantation program. So before I get into the actual case report and the case report device, I want to talk about 2 things. I want to talk about a little bit about ARDS, and I want to talk a little bit about mechanical ventilation. Some of this is going to overlap with Dr. Scott's presentation earlier. So most important thing is we have to define ARDS. So the initial definition of ARDS was published in 1994. It was a European Consensus Conference definition. This was later replaced, and this is what we actually go by today, which was published in JAMA in May of 2012. It is endorsed by the American Thoracic Society, and it's actually a product of the European Society of Intensive Care Medicine. So the 3 categories, as you see up there, defining ARDS, mild, moderate, and severe, and it also shows the 4 ancillary variables that tie into this definition. So when you really dissect the definition here, you can see on the bottom of the curve, you see mild ARDS, you see moderate ARDS, and severe ARDS. So the ones that are highlighted in blue, those are the accepted interventions. Those are the ones that we have enough literature, enough evidence to support those interventions. The ones that you see in yellow, again, we don't have sufficient evidence yet. So those are the things you can see ECOR actually falls in that category. So ARDS, again, it was first recognized in 1960, and actually during the Vietnam War, they used to call this shock lung, and it was later realized that it's not just common to the war patients. It was actually involved with patients of any age. So later on, it was replaced with the actual term of acute respiratory distress syndrome. The mortality of this is still extremely high. It's estimated between 26 to 58%. The variability in this mortality is because of the severity. It depends. Is it mild, is it moderate, or is it severe? But again, mortality is extremely high. And it's also dependent on predictors, patient comorbidities. So looking at mortality, here's a study that was published in 2008. They actually looked at 72 studies. It was a meta-regression analysis. The sample size was large, 11,426 patients. And they actually looked at different categories, but just looking at it, you can appreciate how high the mortality is, anywhere from 35 to 50%. Another study here actually looked at a 16-year period. Even though this study actually showed, it was published about a few years ago, it actually shows a decline in mortality, and you can appreciate that it has reduced to 14.6 because of our new strategies for ventilation. However, you still have to realize that the mortality still remains extremely high. So it is a huge economic and a financial burden to us. This was published just a few months ago. Again, if you look at it, they actually looked at, in their initial search, 1,265 different papers, and they actually categorized them between retrospective, prospective, and randomized controlled trials. And even in those categories, you can see the range was anywhere from 26% to almost 50%. Again, very high appreciable mortality for acute respiratory distress. A little bit about mechanical ventilation. Dr. Scott earlier alluded to wanting to get rid of the mechanical vent. Yes, I think that may be the future. I think we're far from it. I think there are a lot of other hurdles we have to get through. So just a little bit about mechanical ventilation. What's ugly about it? Well, it causes villi, which is ventilator-induced lung injury, okay, because of the high pressures, because of the high volumes, and because of the high respiratory rates. Okay. Mechanical ventilation also promotes ventilation-associated pneumonia, and these patients require to be sedated and paralyzed. Okay? So if you look at conventional ventilation, basically causes barotrauma. If you look at the tidal volumes that are required, or what we go by as conventional ventilation, it ranges anywhere from 6 cc's per kilo of predicted body weight all the way up to as high as 10, sometimes 12 cc's per kilo predicted body weight. Predicted body weight is actually calculated based on height and gender. So it's a little bit different than ideal body weight. If you look at protective ventilation in literature, it's defined by using lower tidal volumes and lower pressures. So what happens is when you do this, it's a double-ended sword. You actually get an increase in CO2 and you get respiratory acidosis, okay? So when you have that, well, what happens after that, like Dr. Scott alluded to, it affects your right-sided heart failure. So your pulmonary vascular resistance goes up and your cardiac contractility goes down. So how do we fix that? This is where ECOR comes in. Okay, here's a study published in 2012 looking at 485 patients. When you look at this, even you can appreciate the tidal volumes on the bottom from anywhere from 4 all the way up to 12, and you can see that the hazard ratio of mortality goes up significantly. So for every cc per kilogram of body weight, you're affecting the relative mortality by 18%. It's significant, okay? Another study here, again, large study that was published just last year. It looked at 50 different countries. They looked at 435 hospitals, and over 29,000 patients were screened. When you look at the probability of survival, again, much better survival rates when the driving pressures are less than 14 on day 1 of mechanical ventilation. Again, you can appreciate that. The same data set that looked at plateau pressures, again, driving pressures, same curves. Again, you can see the mortality goes up significantly as the plateau pressures go up. Another study here, 861 patients, again, old study, published in 2000, but again, a huge difference, almost 9% benefit of low tidal volumes, 6 cc's per kilo versus the traditional 12 cc's per kilo. So again, there's plenty of literature to show this to us. So again, when you the key is to try to minimize barotrauma to the lungs. That's the goal when you talk about protective ventilation strategies. So, but when we're doing this, what happens is we're increasing acidosis because of the rise in CO2. So I'm going to talk about ECOR a little bit. This is nothing new. I'll have a slide later on, but the types of ECOR, the one that Dr. Scott discussed earlier was basically the arterial veno ECOR system, and that's basically a pumpless. It could be pumpless or pump assisted. The disadvantage of this is that you're compromising the arterial. It requires an arterial stick. Okay, so you can have leg ischemia, things like that still exist. So it's an issue. The one I'm going to focus on today is the VV ECOR system. We actually use the HemoLung system, and I'm going to really get into the system itself. You can do ECOR with conventional ECMO at lower flows. Again, a little more invasive. There are other systems by the Novolung that Dr. Scott talked about. IL Active, which is actually uses a small pump, or it can be an ILA Novolung ventilation, which just uses pretty much what he did with a Novolung oxygenator. And then there's a decap system as well. So again, eCore is nothing new. It was introduced first in 1978. So it's just gained recent interest, a lot of recent interest. So it's nothing new. So it's published in 1978. A study that followed later on in 1994 by the Morrison group, they looked at 40 ARDS patients. And they actually said that there was no survival benefit using eCore as a CO2 removal strategy with ventilation. They also had a very, very high complication rate. Actually, the study was stopped because of that. 33% complication for bleeding and clotting of 20%. And I think at the time that there was also a large lack of experience. Their conclusions of the study was that there was no survival benefit, and they did not recommend extracorporeal support as a therapy for acute respiratory distress. This is 23 years ago. So the only intervention that's been proven to give us a survival benefit in acute respiratory distress syndrome is volume and pressure limited ventilation strategy. Okay? This was demonstrated by the Cesar trial. Most of you are familiar with that. It was published back in early 2000. But this is where we learned this from. Now, some of the observational studies, prospective studies, some of the animal studies, a lot of European studies is also suggesting that eCore can be very useful in reduction of ventilator-induced lung injury by achieving those tidal volumes and decreasing the plateau airway pressures below the standard of practice. And the only way we can achieve these is by implementation or in conjunction with a system that is going to remove the CO2. Okay? So the strategy here is to have ultra-protective ventilation strategy where you're actually having the ventilator set sometimes as low as 3 cc's per kilo predicted body weight, sometimes 2 cc's per kilo predicted body weight in conjunction with a device that's not as invasive as ECMO is. A little bit about oxygen CO2. Again, we heard this earlier, so I don't want to spend too much time, but again, oxygen is carried by hemoglobin, most of it, 97 to 98%. Now, if we didn't have oxygen, if you just do some calculations for fun, if we didn't have oxygenation, carrying capacity of hemoglobin, and it was just all based on solubility. So the solubility of oxygen in plasma is 0.003 cc's per cc of blood, okay? Very, very low. So if we're dependent on just plasma to oxygenate for us, if you do the math on that, we would require 83 liters of flow to sustain our bodies, okay? It's crazy. So thank God for hemoglobin. Anyway, if you look at this calculation based on a patient with, say, 12 grams of hemoglobin, SATs, SaO2 and SvO2, 99 to 100 versus 70, 75%, we basically need about 240, 250 cc's of blood per minute. Okay, this basically translates to about 5 liters of blood flow. Okay, CO2 doesn't require that kind of blood flow. It's mainly dissolved in plasma in the form of bicarbonate. At rest, you produce about 200 cc's per minute. And again, you saw the curves earlier that the dissociation curve of CO2 is much, much different than the dissociation curve of CO2. CO2 is about 20 to 25 times more soluble than oxygen is. Okay, so again, don't require that much flow to remove CO2. Case report device, we use the Hemolung Respiratory Assist system. This is produced by Alung Technologies. They're based out of Pittsburgh. Company was founded in 2005. They did some pre-market safety and feasibility studies in 2010 in Germany and India. They received their CE mark in 2013, which is basically an FDA for Europeans in 2013. And in the US currently, this device only has the HD exemption, which is the humanitarian exemption. There's, at current times, this is information from the company, 6 emergency use cases in the U.S. in 5 hospitals. 1 hospital actually did 2 cases. At the time when we did this, we were only the 4th hospital. It received its designation of expedited access pathway from FDA just a few years ago, and this fall they're actually going to start a large pivotal randomized trial for Alung Technologies. So hopefully we're part of this study. When you look at to actually get into the system itself, it's composed of literally very simple, a cartridge and a controller system. Okay, they don't obviously call this an oxygenator because that's not what it does. So they call it a cartridge. You see a little cross-sectional there. It actually has an internal core that also spins besides just the pump that pulls the blood into the cartridge. So I'll talk about that a little bit. They have a patented mixing, what they call as active mixing, and we'll get to that here in just a minute. But the cartridge basically houses a cylindrical bundle of siloxane and heparin bonded hollow fiber and pump. So it's integrated. It's positioned around a core that spins simultaneously, drives the blood flow through the cartridge in a centrifugal fashion and removes CO2 under negative pressure through a fiber lumens. So it actually has vacuum on it. Surface area is very small, unlike our oxygenators, 0.59 meters squared. So very, very small. Total prime volume is only 260 cc's. The active matrix technology refers to a secondary flow pattern that's created by the rotating core internally and the geometry of the blood flow path in the cartridge itself. The secondary flows actually cause mixing of the blood near the surface of the hollow fiber membranes, which actually increases the efficiency of the CO2 removal. For you physics people, this is what they call as Taylor vortices. Again, just a schematic diagram of how it works. Again, the picture on the bottom there left, your oxygen, your gas comes in, CO2 comes out, and you can see the internal core actually spins, causing a secondary flow. The controller system, the great thing, we had a question earlier about monitoring how much CO2 is actually removed. The Hemolung system actually tells you in real time how much CO2 is removed at any given second. And it also tells you what you're flowing and your RPMs and how much sweep gas you have. So very simple instrumentation. It does keep about 7 days of historical data that you can go back and look at. 2 settings on the Hemolung that you change, which is pump speed and gas flow. That's it. So the sweep gas flow through the system is self-generated internally, and it's digitally controlled by an internal vacuum pump. Okay? It automatically detects, if you use a pressurized gas source, it will know that you have a pressurized gas source. If you don't hook up this pressurized gas source, it uses ambient air as a source. So it's pretty smart. It knows what you're doing, but the pressurized gas source is not required. The cannula, it's a dual lumen, it's a unicable design. It's a 15.5 French, small size, low resistance, flow rates of 350 to 500 cc's per minute. You can either put this in the IJ position using the jugular version of the cannula, or you can use a femoral cannula, either way. But again, only a single stick in the venous access. So they actually have 2 cannulas. You can see the top one is actually made for the femoral approach, and one on the bottom is actually made for your IJ. So it's very nice that the company actually made the actual curve into that cannula, so it's a lot easier to manage that patient. So to get into the case report itself, this is a gentleman, 18-year-old patient, BSA of 2.2. He had a history of testicular cancer, November 2013, and then he actually went right inguinal orchiectomy. He was treated with 3 regimens, as you see there. He had previously also a history of respiratory arrest. He was intubated with extensive ICU stay, and he also had a trach in December 2014. Anyway, after he had been treated with chemotherapy for his cancer, they actually found a residual mediastinal mass in the left lung, and it was actually extending into the left atrium. So this patient was actually at MD Anderson Cancer Center, which is about 4 or 5 blocks from us. And it's one of the world leaders in cancer treatment. So anyway, he underwent a left pneumonectomy with an in-block partial excision of the left atrium. He did go under cardiopulmonary bypass for this procedure, obviously because of the involvement of the left atrium. He was extubated without any issues shortly after the surgery. However, post-op, a few days later, he actually was febrile and developed an extensive right lung infiltrate. So his condition worsened, even though they had put him on broad spectrum antibiotics. They basically assumed, because of the fever, the elevation in white count, that he probably had some kind of aspiration pneumonia that may have occurred during his surgery. He was reintubated about 5 days after his surgery. He developed severe hypercapnia. He was also hypoxic at the time, and he developed this systemic hypotension, which required quite a bit of epinephrine, 8 mics per minute. Okay. Transthoracic echocardiogram revealed that there was some mild tricuspid valve regurgitation. His RV systolic pressure was 40 elevated, and he also had a leftward intraventricular septal deviation. Again, indications of respiratory acidosis causing and the effects it has on right heart failure. They instituted Flolan on June 9th, basically just about 6 days later from his initial surgery. On the 11th, he was more hypercapnic than he was hypoxic. Patient remained acidotic despite paralytic sedation and, obviously on mechanical ventilation in the APVR mode. FiO2 requirements increased without radiographic changes, basically suggesting this was ARDS, possibly just induced by ventilator lung injury. Consult at this time has already gone out to us for artificial support. So during this time, we're actually working in the background trying to see what we're going to do with this patient. So the issue here was that the CO2 elimination was inadequate. It wasn't improved even in a setting of an already traumatic high ventilator settings. Plateau pressures were well over 30 centimeters of water. Okay, so that's not a good thing. That's causing a lot of barotrauma to the lungs. So oxygenation wasn't an issue, and if it was, we can control that with FiO2. So we opt for a minimally invasive mode. So we're actually thinking about doing something in an E-core fashion. We weren't thinking in the VA E-core type just because he had undergone a major surgery, also requiring cardiopulmonary bypass. We submitted, started having discussions with Alung, started working with paperwork with the FDA, paperwork with MD Anderson, paperwork with our IRB. So we were up all night doing this stuff for 24 hours before we actually transferred the patient to our hospital on June 13th. So I can tell you it was a huge challenge. I remember personally being on the phone half the day, personally going down to the docking system at 6 o'clock at night, uncrating the hemolungs on the dock. It was definitely a team effort, and you'll see the results very successful. Anyway, on arrival to our institution, he arrived around 2 o'clock in the morning. So obviously, came to us a lot later than we thought. At this time, respiratory rate was 22, FiO2 about 65%. Again, not that high on oxygenation there. Plateau airway pressure is pretty high, 36 centimeters of water. Tidal volume was only at 4 cc's per kilo body weight, right? But remember, he's only got one lung, okay? PEEP was at 10 centimeters of water, and its compliance was horrible, only 8 cc's per centimeter, okay? By now, Levophed had already been dropped to about 1 mic per cc, which was great. We are the only institution in the medical center that actually have nitric oxide, and we actually initiated inhaled nitric oxide at this time, made some changes. This is his x-ray, obviously post-pneumonectomy, ARDS induced by lung by ventilation, or is it aspiration pneumonia? Initial series of blood gases, as you see within the first 4 hours when he arrived, from almost 2 o'clock to about 4 o'clock, you can see clearly acidotic state with the high CO2. We met all the institutional and corporate regulations, were satisfied. Alung provided us with all the instrumentation we needed. They provided us with a clinical specialist, and they also provided us with the clinical engineer the day of insertion. We administered heparin 80 units per kilogram, but this is what the manufacturer recommendation is. Cannula was percutaneously introduced in the right femoral vein. Again, we opted not to go to the IJ to prevent a pneumothorax, especially through the surgery he had just gone through. So it was a single stick, 15.5 French, right femoral vein. We initiated ECOR around 7 o'clock in the morning that day, so 5 hours after he had been received at our institution. Blood flow rate was about 450 cc's per minute. Sweep gas maximized at 10 liters per minute. Vent at this time, we had made some changes and they had gone up to 100%. We were removing about 76 cc's per minute on our CO2. 4 hours after initiation, you can see a significant depreciation in his CO2 from 73 to 53. And his pH obviously also improved from 7.28 to 7.44. Tidal volumes were decreased from 4 cc's per kilo to 3.5 cc's per kilo. Plateau pressures dropped to almost 11 centimeters of water. Huge improvement already. Obviously, this caused a reduction in the pulmonary vascular resistance. We were able to discontinue the norepinephrine infusion. So we maintain heparin, titrated the heparin at infusion to maintain a PTT of about 60 seconds. So you can see here, 20 hours after initiation, again, plateau pressures well below what we want for protective ventilation strategies. 20 centimeters, CO2 is at 46, FiO2 gone from 100 to 50%, PO2 normalized. Here's a graph just kind of showing you the trend over the first 20 hours. Again, huge improvement in CO2, increase in pH. PO2 is fairly stable. At 40 hours, again, FiO2 is reduced well under 30%. PO2 is great, CO2 is great. Again, graph just kind of showing you what happened in that the next 48 hours. Oops, sorry. Termination of ECOR. We decannulated this patient 71 hours. The pump time was 71 hours and 15 minutes, so about less than 3 days. He was extubated within 24 hours of decannulation. We observed no ECOR-related complications at all. The patient did not get any blood products, and you can see the data here on the Hemolung pump. Apologize for this fine print. It was kind of hard to get this in, but you can see the pump flow rates remain pretty steady at about 470 to 480 cc's, RPMs at about 1400, and then you can see the sweep rate drastically coming down from 10 all the way down to a point when we actually turn the sweep off, and CO2 removal obviously goes down as the sweep comes down. And this was his X-ray post-ECOR. Again, although the device hasn't been used in Europe quite a bit, I think there's over 600 reported cases of the Alung system. This is the first case that's going to be published of its kind in the U.S., and we were the 4th application of the Alung technology in the U.S. So just other laboratories real quick, looking at it, plasma hemoglobin, we did have a little spike in plasma hemoglobin, but again, it started trending down. Again, no change in hematocrit. Like I said, the priming volume of the cartridge is very small, 260 cc's. The platelet count, again, minimal reduction, almost stayed at baseline. The PTT obviously titrated to be between 60 seconds. There was at one point, we ran a hit panel on this gentleman at one point, and ELISA was positive, so we did switch him briefly to Angiomax, just to be safe that he didn't have some kind of heparin-induced thrombocytopenia. But we decannulated him so shortly after that, we never followed up on the SRA. Lactate LDH, again, within normal range. LDH went up, but again, it trended down pretty fast. Discharge hemoglobin on June 17th, so 4 days later, he was sent back to MD Anderson, normalized blood gas. This is our patient with his mom. He's 20 years old, doing 20-year-old things today. Other devices, very quickly, you have the Prismalung that's out there. Again, this is what's used for CRRT. Today, they actually are using that system, incorporating with a cartridge that removes CO2. You have the ventilator, the Novalung, that was discussed a little bit earlier. McKay has a PALP system, pump-assisted lung protection. Again, it's a cardio help system. The DCAP Smart system. This system is interesting because if you just do CO2 removal, it's called the DCAP system. And if you actually do CO2 removal in conjunction with CRRT, it's called the DCAP Smart system. So you can actually do dialysis at the same time you're doing CRRT. So very efficient systems are coming along. Now the Hattler catheter was discontinued by Alung Technologies. This is, I think the industry was just not ready for it, but it was basically a balloon pump with a membrane around it that pulsates. Interesting concept. This is where they came up with the Hemolung technology. But in the future, I don't know, this may come back. Just some pictures. Here's the picture on the very top showing you the actual Hattler catheter that Alung actually had initially. It's actually a balloon catheter that helium inflates just like a balloon and had a membrane actually around it. Just pictures of some of the systems there that are available. Again, I think this is going to be the up-and-coming strategies for ultra-protective mechanical ventilation. Again, I think we need mechanical ventilation, but we need to be very careful that we are not inducing more trauma to these lungs than they already are. So, in essence, we need more data for ECOR. Again, I think we have a lot of observational studies that's suggestive that this technology is very beneficial in conjunction with mechanical ventilation. Future implications, again, more studies are needed. There's a trial that should be coming, concluding soon. It's called a supernova trial. Don't confuse this with the supernova trial in the US, which had to do with stenting. Okay, this is an ARDS supernova trial, European study, large study, including about 1,500 patients. And this is actually going to look at ultra-protective lung strategies with extracorporeal CO2 removal. So is there a benefit of using this? And so this, I think, is going to tell us a lot. This data will tell us if there's a justification for using this technology. And so I thank you for your attention. I'll open the floor for any questions. Thank you.